Neurology and Population Health Science and Policy, and the Bludhorn Professor of International Medicine at the Icahn School of Medicine at Mount Sinai. She is a health service researcher, epileptologist, vice chair for the clinical research neurology, and chief of the division of health outcomes and knowledge. And psychiatric comorbidities, and determines how best to optimize these outcomes in persons living with epilepsy. Her team uses a variety of data sources: electronic health records, administrative data, registry data, and statistical approaches to study neurological outcomes and to develop prediction tools and decision models to help clinicians provide the best possible care to persons living with epilepsy and other neurological conditions. She is also involved in knowledge translation research, including development of e-tools and apps to enhance the dissemination of evidence-based practice to improve epilepsy and other neurological outcomes. The learning objectives of this webinar are to communicate to patients and families as appropriate and to educate patients and family about the disease specifics, example, prognosis, self-limiting, risk factors, etc. We have the honor of saying hello to Dr. Jetté today. Thank you for being with us, Professor Jetté.
Thank you so much for the kind invitation, Dr. Chua Urea. It's such a pleasure to join you and all the YES members. I wish I could be with all of you in person. It would be wonderful to catch up with all of you. Hopefully we get to meet in person soon. Mm-hmm. I'm going to share my screen. Can you see my slides okay? Perfect. So over the next, well, first of all, welcome everyone and thank you for joining us today. It's such an honor to be among the YES member who have been so dynamic and such an important group of members to ILAE. We really appreciate all your contributions. I don't have any relevant disclosures today. And Dr. Chua Urea already discussed some of the learning objectives. Over the next 45 to 50 minutes, I'm going to discuss particularly 3 topics in general. These will include depression in epilepsy, so some of the epidemiological data and how they're influencing our clinical practice. I'm going to talk about some predictors of mortality in epilepsy and briefly discuss ways to minimize premature mortality in epilepsy, and then touch upon how COVID-19 is impacting the lives and care of people with epilepsy. And so first, starting with depression in epilepsy, sometimes people will say, well, of course, she's depressed, she's having seizures, she lost her job, her husband left her. But you know, this quote is really important from a person living with epilepsy who said, having epilepsy doesn't mean you have to expect and cope with depression. you have as much right to help and support as anyone else. And so it's really important to keep that in mind, that although there are multiple factors that may worsen or make depression more likely in people with epilepsy, we still have to address it as we would for any other individuals. So how frequent is depression in epilepsy? This is a systematic review we did. We published now some time ago, but the data haven't changed that much. And what we found is that overall, the pool prevalence of active depression was about 24% in people with epilepsy, and it ranged anywhere from 13 to 37, depending on the ascertainment method that was used. But overall, at one moment in time, about 24% of people with epilepsy suffer from depression. There's been a more recent systematic review published in 2017 by the group in Australia, looking at both anxiety and depressive disorder in people with epilepsy. And our estimate was 24%. They found an overall pooled prevalence of depressive disorder in people with epilepsy of 23%. So very consistent. When it came at anxiety, it was around 20%. And there's also been a group that's looked at anxiety and depression specifically in youth with epilepsy. And the numbers are a little bit low, but still much higher than in the general population. This is work that had been done by the late Jose Zentino, using the Canadian Community Health Survey, which is administered to over 30,000 people every other year in Canada. And during one of the cycle, they actually administered the Composite International Diagnostic Interview, which is a structured psychiatric interview to participants of the survey. And what you can see, there were over 36,000 people without epilepsy included and over 250 people with epilepsy. And so these are, this is one of the studies that is population-based. And what it shows is that if you look at lifetime mood disorder, again, in epilepsy, it's around 25% and around 13% in those without epilepsy. Any mental health disorder, lifetime is close to 36% in people with epilepsy and 20% in the general population. And if you look across all the different mood and anxiety disorder and so on, and suicidal ideation, it's higher in those with epilepsy than those without. There has also been some very elegant work done looking at the bidirectional association between epilepsy, suicidality, and psychiatric disorder, looking at people who have depression. Is there, do they tend to develop epilepsy more than people without depression, and vice versa? People with epilepsy, do they have a higher risk of developing depression after? And again, the study showed a bidirectional association with an increased onset of psychiatric disorder and suicide before and after epilepsy diagnosis. Again, highlighting the importance of these comorbidity and their possible impact on people with epilepsy. This is a more recent study published by the group in Calgary, which I was part of. And this is Dr. Josephson, who is the lead author of this study. And we were interested to look at the association of depression and treated depression with epilepsy and seizure outcomes. This was an observational study of a population-based primary care cohort in adults age 80 to 90. It included more than 10 million people, of which close to 230,000 actually developed depression, and over 97,000 developed epilepsy. And so that the prevalence of epilepsy was around, well, actually the incidence was around, it was about 1% of people developed epilepsy during the study cohort time. And these data included the Health Improvement Network data from the UK and the Calgary Epilepsy Program data from Calgary, Canada. And what Dr. Josephson found is that if we look over time, and if we look at the cumulative hazard of developing epilepsy, he showed that those who don't have depression have a lower hazard of developing epilepsy over time. Those who have depression, it's higher. And those who are receiving treatment for epilepsy, they have the higher hazard of developing epilepsy over time. Now, even when we looked at counseling alone, so I should highlight that treatment wasn't just medical therapy, not just antidepressants, for example, but also counseling. And even when we looked at counseling alone without an antidepressant, that association was still there. So suggesting that it's more a marker of severity of depression rather than antidepressant that increase the risk of epilepsy. And so they're suggesting that there are likely shared mechanisms between epilepsy and depression that make their co-occurrence more likely. Okay. So why is it so important to screen for depression and anxiety in epilepsy? Well, as I've shown you, they are the most common psychiatric disorders in people with epilepsy. They have really high lifetime prevalence, much higher than in the general population. And if we take depression, for example, we know that people who are depressed are less likely to take their medication. They tend to have more side effects from medication. They also have a higher risk of premature mortality. Depression is associated with poor quality of life, and those who have depression and epilepsy also use more health resources than those without. And so there have been a lot of quantitative data looking at how common is depression and so on, but I want you to also think about, what additional information can we get when we are studying depression and epilepsy to better understand the impact on people with epilepsy, but so also think sometimes about, would it be worthwhile to get qualitative information and actual perception from people who are living with epilepsy, how certain things are affecting them and impacting their mental health. So this is an example. This was a study where it was a longitudinal cohort study where we looked, there was a shortage of the medicine clobazam in Canada, and it began very abruptly. And there was a crisis because many people couldn't get it. Our phones were ringing off the hook. The nurses, the doctors, we were trying to find some of the medicines for the patients. And this was across Canada. I was president of the Canadian League Against Epilepsy at the time. And we were trying to see what are we going to do because some people just couldn't get it. And it was really a crisis for many of them. And we wanted to understand, we thought that one way to change policy is to show health policymakers and government how it's impacting people living with epilepsy, these shortages, and what can we do to reduce their occurrence. So we wanted to study the impact, and we did it very quickly. Within a few weeks of the shortage starting, we were able to study this. We had a registry of all the patients in our practice, so we were very quickly able to identify who was on this medication. And we did cross-sectional questions. We had been administering patient-reported outcomes questionnaire at each visit. So we already had baseline assessment of depression, like the depression screening tool and some other outcomes like quality of life. But we decided to administer those questionnaires through a telephone interview, but also do some open-ended question to understand more the impact. And 84% of eligible patients agreed to participate in the study. And we learned that over 70% in that very short time had already had a medication change because of the shortage, which is quite significant. What was interesting is it had been about 5 or 6 weeks since the shortage had started. And when we looked at their patient-reported outcome before the shortage and at this time now, there wasn't really any difference quantitatively. But then we started looking at the things that they were telling us, because if we just published this, we would have said, well, it didn't really have an impact. But when we looked at what they were telling us, and I want to focus particularly on the psychological impact here, 93 times during the interview, someone referenced something related to fear and anxiety about the future and the psychological impact of the shortage. And I want to read one of the quote from a patient who said, "When I first found out about the shortage, I panicked and I immediately worried that I was going to run out of my pills and thought far ahead. I have a problem with catastrophic thinking. I thought far ahead about if I run out of frisium, which is clobazam in Canada, and if I have a seizure, and worried about losing my license and house and then losing AISH, which is the social support for this person. When it got to that point, I thought about killing myself. The anxiety got that bad, and we would never have known this unless we had these qualitative data. So just something to keep in mind that sometimes, it's important to get a little bit more than just questionnaire and so on. What about in terms of treatment of depression and epilepsy? We've talked a lot about the impact of various things on mental health in people with epilepsy, how common they are, but is depression being treated in people with epilepsy? And this is one of our study where we administered semi-structured interviews and consecutive adults with epilepsy in our program. And what we found, and this is a program with Professor Sam Weeb and really amazing epileptologists. I was so lucky to work with them, and I still love working with them. And we were very, I thought we were doing a great job at making sure that if our patient had depression, we were addressing it and all that. We actually found that 70% of those with epilepsy in our practices who had depression were not getting treatment for it, actually. So, I guess people come and they're happy, and maybe we weren't always screening for it because they seem so happy. And, but when we actually formally studied it, we found there were more people who had depression than we realized. And this has been consistently reported in many, many studies. We also found that of those who had depression in our study, 1 in 2 or 50% also endorsed suicidal ideation. So this was quite striking. And this is a more recent study now published just this year, again from the Australia group. They included over 270 community-based outpatients with epilepsy, and they found that only 30% of those with an anxiety disorder were receiving treatment for it, and only about 50% with depression. So now this is a number of years later, and again, we're seeing the same pattern that people with epilepsy who have depression and anxiety don't seem to be getting treatment for it. So this is Professor Gus Baker, who's done a lot of work to study outcomes in people with epilepsy. And he had said, because it's associated with the risk of suicide, depression must be considered a life-threatening disease. And I think this is very, very correct. And it's important for any of us who are involved in the care of people with epilepsy to be able to identify these comorbidity, especially the mood disorders and anxiety, and be familiar with the risk factors so we can help our patients with these comorbidity. In fact, these are the American Academy of Neurology epilepsy quality measures, and they do recommend that depression and anxiety screening be done for people with epilepsy during their outpatient visits. So how do we screen for depression in epilepsy? Some people say, it takes too much time. I'm not a psychiatrist. It's too difficult, and I don't have time. There's so much to talk about with side effects of medicine and which anti-seizure medicine and so on. But it is important, and it can be done quickly often. So this is a systematic review where we looked at, what are the validated screening tools so that you don't need a full psychiatric assessment on everyone right away. Can you screen for depression in people with epilepsy easily, and what's been validated? We identified 30 studies at the time. This was up to 2016. And the papers were in 3 different languages, but in fact, they were over 13 language depression screening, more than 13 identified. We had 30 studies. One thing that is unfortunate is that they were mostly all in adults. There was only 1 study in youth, so a lot of work still needs to be done for adolescents and children. But you can see that the NIDI, or the Neurological Disorder Depression Inventory for Epilepsy, was the most commonly validated tool to screen for depression in epilepsy, and it was validated in 13 languages, and that's available in the public domain. You have other ones like the Beck Depression Inventory, the HADS, Hospital Anxiety and Depression Scale. These ones, you need a license for them. And then the PHQ-9 is also commonly used, the Patient Health Questionnaire. There had also been some validation. The NIDI only has 6 questions. It's very easy to use. Everything is a struggle. Nothing I do is right. Feel guilty. I'd be better off dead, frustrated, or difficulty finding pressure from never to always or often. And then if the score is more than 15, it suggests possible diagnosis of major depression. And if that's the case, then you need to ask more questions to confirm that is correct and that they do have depression, and decide on next step. When we looked at other cutoff points, because the original study said if you have more than 15, we found that many studies validated other cutoff points, and even at more than 13, still there's a good chance that they may have depression. So what we found is that in terms of balancing sensitivity and specificity, to make sure that we're identifying the correct people and that they do have it, and that it's not, that it is sensitive enough, but still accurate, that anything from about 13 to 15 and higher, that the chances that they probably have depression. The other one that's available in the public domain is the PHQ-9, or the Patient Health Questionnaire. This one, as you know, maps directly onto the DSM-5 criteria for depression. And that one also performed quite well. And sometimes if you are using it more for research and you prefer not to include the question that's indirectly linked to, suggest possible suicidality, and you want a briefer item, the PHQ-9 performs equally to the PHQ-8, actually 8 and 9. Even if you drop that question, you have similar accuracy. So what we found is that, most depression screening tools actually performed quite well, regardless of whether they included symptoms that overlap with anti-seizure medication side effects or cognitive symptom. Most of them had good sensitivity and specificity, good negative predictive value. The NADI was the most commonly validated one. And really the best tool you use depends on, maybe you need it in a certain language because of where you live, or you need something that's a little shorter, or you want to include the suicidality question. So all those things depend, but the most important thing is to screen for it, and I think that whichever tool you use in general, they do perform better, fairly well, and it's better than not doing it. There's been a more recent systematic review looking at anxiety screening tools, a very similar methodology from the depression paper. And they found that the GAD-7, generalized anxiety disorder, and the hospital anxiety and depression scale were the most commonly used to screen for depression and epilepsy. And the GAD in particular is available in the public domain and also pretty quick to fill out, so commonly used. One caution I would say is that the PHQ-2 alone, which is just a 2-question about mood, and from the PHQ-9 has very poor sensitivity, more like 20% and all that. So I would probably not recommend, but otherwise most of the other tools are pretty good. But what about managing depression in people with epilepsy? Who should be doing that? Because some of you may feel like you're not comfortable doing that. And in fact, there is a lack of consensus in the epilepsy world. There was an ILAE questionnaire that went to 420 individuals, health professional who were members of ILAE. And you can see that who should be responsible: primary care providers, psychologists, psychiatrists, neurologists, nurse specialists, neuropsychologists, epileptologists. There is no agreement as to who it should be. What about how do we treat it? We need more information, This is a Cochrane review looking at antidepressant for people with epilepsy and depression. It's a systematic review, and they found that the evidence is very limited with a high risk of bias. There was one small randomized control trial with 64 people suggesting that venlafaxine was associated with a significant improvement in depression and epilepsy, but more information is needed. And there are a lot of self-management tools and so on that are also available now through the, through some of the Living with Epilepsy Well Network and other networks and, other programs. And I think for now, even using regular kind of guidelines for the general population for management of depression is a good idea until we have more information specifically for epilepsy. So when it comes to depression and anxiety and epilepsy, there are some gaps. We don't have a lot of information in terms of in children or those with intellectual disability or older adults. We need more research in this area. And we need a little bit more in terms of, are people being treated for it? How should we be treating people with epilepsy who have these conditions? And does improving these improve outcomes? We suspect that it would, but we need more information in this regard. So I'm going to move now to mortality in epilepsy, another very important aspect that we always want to address in epilepsy care. These are excellent systematic reviews published. This one on premature mortality in low and middle income countries, and the second one I'm going to show you is in high income country by the Epidemiology Commission of the ILAE. And what they found is that mortality in people with epilepsy in low and middle income countries is about 2.6-fold higher than in the general population, with the main causes being status epilepticus, SUDEP, and injuries, all of which potentially could be prevented. And so really important to understand that. And of course, the standardized mortality ratio is higher earlier in the younger individuals because we don't expect them to die so young. So often the mortality is higher, but as the age goes on, still the standardized mortality ratio is higher than in the general population. A very similar pattern here in high-income country, and also similar causes, important causes of death in people with in high-income countries, injury, status epilepticus, and SUDEP. And what you can see is that for people with epilepsy, it's important, of course, to address throughout the life cycle, but especially in the first 5 years is where it's highest, so really important to, when you first diagnose people with epilepsy, to realize that mortality is much higher in the, first 5 years after diagnosis. And so this is an interesting, more recent study looking at epilepsy mortality over time. And it seems, according to the study, which has to be replicated, there may be an increase in epilepsy mortality. This is 1999 to 2007, so an increase here. And what could be, and they tried to explain what might be some of the changes leading to increased mortality. And one possible theory could be the aging population, because you can see here the changes in the leading causes of death, where you can see more people are dying with epilepsy, with vascular dementia, Alzheimer's, also neoplasms. And so these, if there is an increase in these, that may be contributing in part to the possible increase in mortality in epilepsy. So there has also been some great data. This is data from Sweden, where they looked at premature mortality in epilepsy and the role of psychiatric comorbidity. And I want to show you, this is looking at a suicide, for example, and looking to see if somebody doesn't have depression or epilepsy, that's the reference group. So they don't have either condition, and we're going to compare now to these. Now, if somebody has epilepsy, but they don't have depression, the odds ratio, the odds of committing suicide is 3.1, so it's much higher than if they don't have epilepsy. But if they have both epilepsy and depression, the odds is almost 23, very, very high. So very important to think about those. And it's the same with substance misuse, which we don't always perhaps screen for more formally, but something to think about, close to 22. So very high odds of suicide if you have, both epilepsy and one of the psychiatric comorbidity. Looking at something else now, SUDEP, sudden unexpected death in epilepsy, something that we try our best to prevent. It's very important, as you know, very critical. This was a systematic review in children, and they identified 108 cases from 22 studies and found that there was insufficient evidence to determine the etiology of pediatric SUDEP. But I think what this study really highlights is the importance of national registries, because it is difficult to determine the etiology. There have been some study like the Mortimer studies, and of course that have been a very important study to help us understand why this is happening, but really important to have registries. And here's one. This is the SUDEP in North American SUDEP registry study, and they identified 237 definite and probable SUDEP cases among 530 participants. And what they found is that, this was published in 2019, is that many of the clinical features that have been reported to be associated with SUDEP were similar in this study. Young adults, non-adherence with anti-seizure medicine, and frequent generalized tonic-clonic seizures were some of the bigger risk factors. And 70% were in sleep, and 70% they were found in the prone position. So really important to remember that seizures in sleep, generalized tonic-clonic in particular, are really quite concerning. These are the American Academy of Neurology guidelines, the SUDEP guideline, and again, highlighting that, people with 3 or more generalized tonic-clonic seizures per year have a 15-fold increased risk of SUDEP. So we can't emphasize enough the importance of making sure that generalized tonic-clonic seizures are treated in people with epilepsy. So what can we do to decrease mortality in epilepsy? Of course, we need more research to evaluate the best intervention, but there's a lot we know already. And anything that reduces seizures, in particular the generalized tonic-clonic seizures, but also focal impaired awareness seizures where there could be injuries and so on, is important. So early referral for surgery and educational intervention, public campaigns targeting medication adherence, the psychiatric comorbidity, healthy lifestyle, avoidance of triggers. Those are things that are important. Accurate diagnosis. So making sure, sometimes people with frontal lobe epilepsy may be misdiagnosed, so making sure they're referred to an epilepsy program or to at least a neurologist to make sure that they are appropriately diagnosed, the right anti-seizure medication for the right patient. Again, I'm emphasizing the aggressive treatment of generalized tonic-clonic seizures, early surgical referral, injury prevention, treatment of comorbidity, and educating about self-management. I've had people who, just by really establishing a good rapport with the person that you're seeing living with epilepsy in your practice, having a good rapport, that they change their self-management, they make sure they're getting good sleep, they're trying to avoid alcohol, they're better at taking their medicine, and it can make a huge difference when you were thinking they were drug resistant, and in fact, a lot of it was more self-management. So really important to do that. So related to this, what about, does being seen in specialized care settings reduce the risk of premature mortality? So this was, again, our group in Calgary, and Mark Lorison was a student at the time, a PhD student, who did this study. Again, Dr. Weeb was the senior author. And this was a retrospective cohort study using the Alberta, Canada data, and looking to see if, as premature mortality, we thought that it would be higher in specialized setting because they're more complex patients. But in fact, we found something that was unexpected. So there were over almost 24,000 incident cases of epilepsy identified. 40% were receiving care by a neurologist. 9% were receiving care in a comprehensive epilepsy program. The mortality overall was 7.2% during the study period. And what we found is, in fact, that the standardized mortality rate was higher in those who were not receiving any specialized care, followed by those who were receiving neurologist care, and followed by those in a comprehensive epilepsy program. So that the premature mortality was lower in those followed in an epilepsy program than neurologists and then non-specialized care. And you can see here over time, the mortality, cumulative hazard of mortality. The lower line are people who are exposed to a comprehensive epilepsy program, people who are followed by a neurologist, and people who are unexposed to any neurologist or epileptologist. And you can see, and this was adjusting for comorbidity and as many important confounders as we could adjust for. So a very surprising finding. And in fact, within a month, I can't remember if it was the month before or after, but this study was published in the Lancet Child Adolescent Health from colleagues in the UK, who found that among adolescents with epilepsy, greater involvement of tertiary specialists in pediatric care was associated with a decreased all-cause mortality in the period after transition to adult services. So really important, and a very similar type of study showing that specialist care is maybe important for those with epilepsy. So I'm sorry, this is a bit of a marathon. So now the last topic will be COVID-19. And I think because you are YES members, many of you are younger and are earlier in your career and probably had very similar experience and were probably redeployed. So I think you will probably understand this very well. But in the US, we've had close to 32 million cases of people living with COVID, and over 570,000 people have died. The first confirmed case in the US was in January 21st, 2020 in Washington. And you can see sort of the timeline up to November, the cumulative cases. And I live in New York City. So this is sort of the timeline, and mostly from last year, where our peak was really in April. And the first case in New York City was February 29. And in fact, the incoming president of ILAE, Professor Helen Cross, was visiting and leaving the day before back to London. She had just given rounds in my center. So I remember that day very well. That was, the day after she left, we had the first case diagnosed, and you can see sort of the cases over time up to October. In my health system, we have 8 hospitals and more than 4 million annual patient visits, and many ambulatory practices and many employees. So you can imagine when all of this started and New York became the pandemic, it was really challenging to manage all these things and everybody, and making sure everyone's safe, and what would we do with all these visits and making sure people receive care. This is the hospital where I am at, and very quickly we ran out of space. So this is Central Park, which is very, very big. You're just seeing a little portion here, but this is a makeshift hospital that had to be built in Central Park to have more outflow of patients because the hospital became so full. This is our lobby normally, and this is a construction of ICU beds. In the lobby, the Starbucks became a nursing station. So every space that was converted into patient rooms and so on. And for those of you who visited New York in a busy time, this would be, I guess, considered a super spreading event, which was just a regular day in New York before the pandemic. This was what it looked like during the pandemic. And the neurologist redeployment in our center was about a week after the first case, 1 or 2 weeks after the first case was when we were redeployed. At one point in our health system, we had over 2,200 people admitted with COVID-19 and more than 450 people in our ICUs. That was in early April at the peak. And you can see we had over 45 COVID team just in one of our 9 hospitals alone. So many, many COVID team throughout our health system. And I covered at one point Team 13. That was the emergency room internal medicine team. So, it was really important, and many of you know this, that, as neurologists and neurology resident and epileptologists, we don't often have to manage a lot of the medical issues. We have our internal medicine colleagues who help, but so we really had to rapidly get up to speed again and refresh our memory from all these things. We had a lot of support. There was a lot of teamwork, and we had to be flexible. And people are still dealing with many of these issues in many countries of the world, right? I think one thing that we saw was the importance of really being there for the families and those living with epilepsy was very distressing, and there are still some areas of the world where the people cannot have visitors, and there are still high cases of COVID, and patients are very scared and lonely, depressed. Sometimes you're not sure if they're encephalopathic or if they're just profoundly depressed from, not having visitor, and confused by all these people coming in with all the PPE and all that. So it was definitely a very challenging time, but we learned a lot. We learned a lot about the neurological complication of COVID-19. As epileptologists, what was the impact on seizures? How do we change the care that we provide? All of that had to be done very quickly. And this I find very interesting. This is a professor of infectious disease and epidemiology in the UK, Professor Paul Garner, who had COVID very early on during the pandemic. And this is what he said. This is 95 days after he was diagnosed. I am unable to be out of bed for more than 3 hours at a stretch. My arms and legs are permanently fizzing as if injected with Szechuan peppercorns. I have ringing in my ears, intermittent brain fog, palpitations, and dramatic mood swings. And here he also said, it's over. I thought it was the beginning of May after the weirdest 7 weeks of illness I had ever had a roller coaster of exhaustion, pain everywhere, tinnitus, headaches, a lot of neurological symptoms, right? And Professor Garner gave me permission to include this in the talk, and he's doing better. So, why do we have neurological complication? There's so much literature that it's impossible to keep up to date, and I'm sure some of you are really up to date with this, but there's a complication of severe disease, so people in the ICU with critical care neuropathy or myopathy, hypoxic encephalopathy. We have metabolic toxic causes with organ failure. It could be due to directly or indirectly to the virus or due to the therapies. Early on, we were using hydroxychloroquine, which we don't really use anymore, but this was used a lot, and that can be associated with peripheral neuropathy and so on. So there are many reasons why COVID-19 is associated with neurological complication. And here are some of the most common. There are many, many studies, and it's hard to give percentages because the studies are all so different. And many of them are retrospective, so things are not systematically evaluated. But we know that some of them are common are encephalopathy, impaired awareness, consciousness, seizures, stroke. Seizures actually not too much, actually. I shouldn't say I put it in purple because I want to talk a little bit more about it. But really encephalopathy, stroke, anosmia, headache, and the neuropsychiatric manifestations are the most common. But you can see that there have been many other neurological manifestations. I'm sure many of you have seen these in your practice. We looked, and as others have in New York and elsewhere, and also in Spain, and looked at the EEG findings of people with COVID-19 who were monitored during, for us, we looked at March to May 2020, very early on in people in our health center who were hooked up. And again, that's a biased population because they were hooked up to video EEG, presumably because they had a coma or they were not waking up or they had spells suggestive of seizures. So keep that in mind. You can see the mean age is older, and 77% were severe COVID, which at the time meant that they were intubated and ventilated. Many had renal failure, 1 in 4 had a stroke. And the main finding on EEG was generalized slowing, but almost half had some epileptiform abnormalities, but only about 8% had seizures, actually. And all of them who had seizures either had a history of epilepsy or had, a seizure, a risk factor for epilepsy. Either they'd had an anoxic injury, or they had posterior reversible encephalopathy syndrome, or they had something that predisposed them to seizures. So we didn't really have anyone with new onset seizures due to COVID-19. And mortality was really high at the time. But keeping in mind, these were very, very sick individuals. Most of them were in the ICU, and this was early in the pandemic. COVID-19 severity in epilepsy, I give 2 examples here, but the data, it's unclear. I think most studies show that it may not be higher in people with epilepsy mortality. I think what's the most important driving factor are if they have risk factor for COVID mortality, like the cardiovascular risk factor, diabetes, hypertension, some of the more severe respiratory conditions and so on, then mortality is higher. In this one study, it was higher, the mortality in people with epilepsy, 23 versus 3.65%. And here it's 9.8 versus 8.5. It depends on when is it studied. Was it early in the pandemic when treatment was different? All those things have to be considered. So I think in general, it doesn't seem like it's higher if there's adjustment for comorbidities and things like that, but we're learning more as time goes on. What about the impact on people living with epilepsy? Well, we know that COVID-19 created a lot of anxiety, stress, caregiver stress, economic insecurity. So that can have a big impact on quality of life and can result in increased seizure, the self-restraint and having to stay home and the lack of social support and all that can have a big impact on psychiatric outcomes in particular. This was a survey from the American Epilepsy Society asking its member, which of the following barriers to care, if any, have your patients experienced as a result of the COVID-19 pandemic? And if we look, this is about 50% here. So over 60% said that many of their patients had been affected by loss of employment or financial stressor, lack of access to healthcare services, restrictions in elective care, a lot of elective tests canceled, as you know, lack of transportation, lack of technology. So there was a switch to telehealth, but many did not have access, and so on. And very similar here, a really well done study looking at care delivery for children with epilepsy during the pandemic. It was an international survey of clinicians, and they found that when you looked at 92% reported changes to outpatient care, or almost 91% reduced access to EEG. There was changes to the management of infantile spasm, and almost 40% restriction in ketogenic diet initiation in 92%. So lots of impact, closure of epilepsy monitoring unit, and so on. This is now a questionnaire in people living with epilepsy, and these are more educated people with epilepsy, actually. So we would expect that things may be a little easier, that they may have more resources to help them. But if we look at ability to get seizure medication from the pharmacy during the pandemic, this was earlier on. Red is actually much more difficult, and purple is made more difficult. So you can see that more than 80% said that they were having more troubles getting their medication. And that's a high percentage, especially that these were mostly educated, employed people with epilepsy. So imagine the impact on people who don't have so many resources and aren't educated. This is a more recent survey. These are people living with epilepsy. These were UK-based respondents, and many of them here said that they had difficulties accessing neurology services because of the pandemic. And this is a more recent survey, so close to over 70% of caregivers and 40% of people with epilepsy said that they had trouble getting access to neurology services because of the pandemic, and 35% almost had mental health difficulties. So these lack of services and all that all made us switch very quickly to say, how are we going to have continuity of care? And let's try to think about, many launched like the use of telehealth and so on. This is before the pandemic. We had no telehealth really in our health system. And after a few months, you can see that there were close to 2,000 people now who had been seen through telehealth services. So it was really, we had to do this very rapidly. The good news is that many studies that have been done looking at the acceptability of telemedicine have shown high acceptability by patient provider, but keeping in mind, I realize many of you, live in countries where access may be more difficult. There are some telemedicine checklists in terms of what should you be talking to them during the visit. There are also decision-making tools. When should you be telling someone they have to come in person for a visit? That telemedicine is not sufficient. So there's some guidance for you in terms of when should somebody be coming in person. And there are also articles on management of COVID-19 in people with epilepsy in terms of thinking about some of the medicines used to treat COVID and how they interact with epilepsy. And this is in Ireland, they have even developed an epilepsy electronic patient portal to try to empower people with epilepsy to be able to report their outcomes and so on, and have more clinician-patient interaction. So a lot of this work is being done. There are lots of resources online from ILAE, American Epilepsy Society, American Academy of Neurology, many other organizations internationally. Here are some of the ILAE resources, and currently there's no evidence to suggest that COVID-19 increased the risk of seizures for people living with epilepsy. There are some case reports, keeping in mind that there are always people who will develop epilepsy. Is it because of the vaccine or not? Most people we see, sometimes they may have a bit of an increased seizure, but most people, what we see is that in general, the vaccine does not seem to increase the risk of seizure or development of new seizures. Here are some resources from the American Epilepsy Society, the Epilepsy Foundation, and this is almost my last slide. So there are many other epidemiological topics I didn't cover. I didn't talk about maternal fetal health. I didn't talk about drug-resistant epilepsy, injuries, fractures, and many other things. So there's a lot more work to be done, and I hope that all of you will contribute to this knowledge. So in conclusion, there are a lot of epidemiological studies that have been published that are informing our clinical practice. There are more studies to understand best practices at reducing the occurrence of negative outcomes in epilepsy, whether it's related to depression, mortality, the impact of COVID, or other consequences. And ultimately, I think whatever we do to help people with epilepsy, always try to consider like an interdisciplinary approach and engage people living with epilepsy in the design of any studies that are developed to inform the studies that are aimed to improve health outcomes in epilepsy. I think for those of you who did COVID-19 service, you know how exhausting it was, but for many, it was a meaningful clinical experience. It's changed some of the ways we provide care, and it's changed the way perhaps we look at healthcare. We've learned about some of the severity and kind of the severe outcomes and so on, but there are lots of resources to help people, and it's a changing field, but things that are improving in many regions. So this was actually on the way home from the worst day of the pandemic in New York City. This is just across my hospital. Usually this would be filled with people, but I was walking home, it was 7:00, and it was the worst day in the hospital, but the most beautiful day outside. So it was a very big contrast for what was happening inside the hospital, which is right here. So thank you so much for your time. These are many of the students and who have helped or coordinators with some of the work I showed you, and key faculty collaborators, and in particular, Professor Sam Weibu has been my mentor and is wonderful. Thank you for your time.
Thank you so much, Professor Jetté, for this wonderful talk. It was very comprehensive and it touched a lot of very interesting and concerning topics that we have to care about all the time in patients with epilepsy. So we have some questions from the audience. The first question is, do you think that suicidal tendencies have increased during these 18 months of pandemic?
That is a very good question. I'm going to be honest with you. I don't know that there are data that have studied this actually. I think it's something that many people we know that mental health, that depression has been higher, anxiety has been higher. So we can only assume that it has. I don't think that data have been published to look at this, and I will look after to see if there have been any recent published study. I think it's a little early to know, but I presume that most likely, just because we know that there's such a strong association with depression and suicide, and we know that that has been much higher definitely during the pandemic. So I presume yes.
Mm-hmm. Especially in children and especially in developing countries, parents have several misconceptions related to mental health care, and especially when it comes to referring patients to psychiatry. What strategies do you think we can use to tackle this?
That is a very good question. I think that whenever we try to remove treatment gaps and barriers to care and all that, it's always important to understand why are these barriers there. So if there's any way first to understand in your area, what are the barriers, and working with family to understand why that is, or even people who have sought care to say, did you have hesitation initially? And if so, why is it, and what made you go, to seek care? So I think getting that perception from, if you have people in your practice and they're reluctant, like trying to learn more why that is, because I think that often, in order to really make sure that we develop good intervention to increase such access to care, we have to understand what the root cause is, right? So I think that really, again, if you have a good rapport with the patient, and I think that this is improving. I think if we look at, depression over time and all that, we are seeing that more people are talking about it. I think that often if some of the things that have worked in high-income countries, for example, is having people who are popular or famous or, come out and talk about, it's okay to talk about depression. It's okay to, so I think that, and I think also what I often tell my patients is that, some of them don't want to be on medication for depression, but I talk to them that the first is like even addressing, like even getting counseling, talking about things, giving them, I say to them, maybe you may not need an antidepressant, but perhaps, you can learn they can help you with some coping skills that are going to be good for the rest of your life, that you can learn from them whenever there is more stress in your life, whenever there is more chaos and more, there's a crisis, or that, you will have these new skills that will help you, and they can connect you with counselor and other people who can help you get through these difficult times. So I think, once they find a good counselor or good mental health providers, if medications are needed and if they have a good rapport, then it's easier. But as you know, even in high income country, there is a lack of resource for the treatment of mental health conditions in our population. So it's very difficult. So I know that I think a lot of it we have to do ourselves, as neurologists, as epileptologists, as, we have to try to do as much as we can, and because it's such a prominent part of our practice, and team up with other colleagues, sometimes just calling a colleague who's a psychiatrist or who to give advice, and sometimes it's necessary if there's not enough resources.
Perfect. There is one question from Sebastian Ortiz. He's a child neurologist, and he has seen a tremendous increase in tics. So he's wondering, in terms of the differential diagnosis, how often have you encountered with tics diagnosis as epilepsy?
That's very interesting question. I'm not aware of a study that has looked at, because most of the study, so first of all, I should say that 30% of people with epilepsy don't have epilepsy. So it's about 20 to 30% developing on this, depending on the study you look at, so they are misdiagnosed. So that's the first thing. We know that many people with epilepsy, many of these studies, what they show is that they either have non-epileptic events that are more, there are different names for it, psychogenic, non-epileptic seizure, non-epileptic events, or psychogenic, or many may have convulsive syncope, or it may be related to cardiac causes and so on. And then there's the movement disorders and so on, like you referred to. I don't think that there are data specifically looking at tic, to tell you the truth. I think that most commonly it is the more psychogenic and cardiac causes. I don't think it's common, but I would definitely, I think with, especially with the myoclonic epilepsies, it could potentially be in the differential. I think with the tic, there's different things because there's you can suppress them often. They may just be in one region, whereas if you have juvenile myoclonic epilepsy, it can be a little bit sometimes bilateral. But so I think there are some features that will help you differentiate the two. But I don't think it's too common, but it definitely is a possibility.
Okay, we have one last question. How to approach telehealth in resource-limited settings? And I guess we have learned a lot about telehealth, like everyone has learned about it, but it's been quite challenging in some settings. How can we approach this in our settings?
Yeah, and I think I would encourage you to work with your local ILAE kind of chapter, reach out to ILAE. They have a telehealth task force, I believe, and because it's not just, it's many aspects. It's broadband, like having access to proper internet and broadband and all that, and there are many things like that it's multifaceted, right? And it's people not having the technology. People, even if they have the technology, it keeps getting cut off. It's very hard to use. It's the knowledge. It's, there's so many things. So I think I would strongly encourage you, because I know there are a lot of initiatives through ILAE where they're trying to look at that, and how I think that it's working with it has to go even like beyond in terms of like government, and also there are more resources, because I don't think telehealth is going to go away, and having approval to use different platforms, because there's the issues of privacy, there's the issues of, all those things. And I know when it was during the pandemic in New York and it was the crisis, we were allowed to use any platforms. We could use Zoom, Facebook, FaceTime, we could use Doximity. We had like many different ways, whatever was easiest for the patient, but then that it cannot go on forever, because some of those things are not, there's no privacy like that can be ensured, but this is where I would strongly recommend working with your ILAE chapters, your regional chapter, and so on, to see if you can, help them to work with your government to see what policies can be implemented. So there's more resources, and there's, certain platforms are allowed and things like that. So it's a little bit complicated and to answer in a few minutes.
Okay. Well, we thank you a lot for this wonderful talk. It was a pleasure to share this webinar with you, and we hope to have you in another webinar soon. And for those of you who connected, thank you for so much for participating. Of September, we'll have a little pause due to IEC. We want to get everyone involved in IEC, so we don't want to interrupt that. And so our next webinar will be the 18th of September. So everyone stay tuned. Thank you so much.
Thank you very much.